obesity, especially when we look at what the alternative is. Because the alternative is, if we don't treat people with diabetes, hypertension, and hyperlipidemia, and bariatric surgery is the only treatment that treats all of these things. We can get them off all of these medications, and maybe it won't be permanent, but will help for a certain amount of years. We're going to have to pay for all of their medical problems, as well as an increasing number of people on disability very young, which is really going to cost us more in the end. So yes, we have to keep people from getting to me, but once they reach there, we're better off treating, because if we don't, it's going to be more expensive down the line from both a societal and medical standpoint.
Right. I mean, it's going to be catastrophic.
Yeah, and especially now that we really do have very good, minimally invasive, laparoscopic alternatives that, I mean, they're getting better too. It hasn't been lost on corporate America that more and more people are interested in having procedures to help them lose weight. So there's going to be a whole new generation of products that are probably about 5 to 10 years away that will again impact on different parts of the body. Most are directed at the stomach, but some are directed, and I've even have patents on a few that are directed in terms of pacing to stimulate the brain or send messages to the brain that may interfere with different things. So this is going to be an active field, and I think that more and more medical doctors are going to have to try to find ways to treat the metabolic side effects, the hypertension, hyperlipidemia, hypercholesterol that comes from obesity.
Well, I can tell you, I think the insurance companies themselves are realizing that it's easier to pay for the surgery than the long-term outcomes, because back in the day, it was really hard for me to get authorization because I'm kind of the gatekeeper, so I'm the first person who has to say, this person has tried X amount of diets, they've been trying to lose weight X amount of years, and the insurance companies would just give me an awful time before they would approve it.
Think about how discriminating. I fight this all the time. One of the things that is asked for our patients is 6 months of a physician-supervised diet. I don't know what a physician-supervised diet is. Does that mean I brought my breakfast here today and you watched me eat it? You would really say, God, you eat too fast. Chew your food. You sound just like my mother. It didn't work back then. It wouldn't work right now. Even though I tell my patients, especially after you have a band or a sleeve or a biped,
slow down.
You got to eat really, 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 really slow. Actually, there's a new product that I've been associated with that actually is a retainer that goes in patients' mouth that forces them to eat slow, almost like the same bite plate that kids have or expanders that children have. So, could you imagine if you were treating cancer and you say, okay, we're going to treat your cancer with behavioral therapy. 98% of women fail. But you know what? We think it makes sense. So we're going to treat it with behavioral therapy. I have people that come to me, and we use a number called body mass index, which allows us to put people's height and weight together. I have people that are diabetic, sleep apnea, have body mass index of 54, and they go, well, he doesn't have 6 months of a physician-supervised diet, okay?
Right.
What is a physician-supervised diet, okay? Back in the day, Camel used to run commercials. 9 out of 10 doctors who smoke Camels. Okay, what is a physician-supervised diet? There has never been a diet that's been shown to be long-term effective in people with morbid obesity. Yes, if you have a relationship with the patient, okay, or there's a new social relationship, and you weigh somebody every week, for a period of time you can get them to lose weight until they stop losing weight when they stop coming to you. And the prevailing explanation is, they became non-compliant. The truth is, they like you, they're embarrassed, so they stop coming. What are you really offering? You're telling them what to eat. You're not changing their hunger. You're not changing their relationship to food. And we have to stop living in the dark ages. This is a biologic process, which is an interaction with our environment that triggers different things in different people. But if behavioral therapy worked, then I wouldn't exist. Okay? If pharmaceutical therapy worked, I wouldn't exist.
Right.
Okay, I am really good at doing anti-reflux surgery. You know how much of it I do a year? 10 to 12 cases. You know why? Because that little purple pill helps most of the people that you see. Okay? So it's a matter of fact of life that if there were things that worked, I would be the last line. Because even though we do surgery through small holes, and the recovery times have gone down, and the return to work, and so many things have improved in my surgical career, it is still surgery.
Right.
Okay, it is still the loss of control of going under anesthesia.
Mm-hmm.
And you know what? No matter how good you are, unless you're going to get rid of wrinkles and make people younger, if there was something else that worked, and even, look at Botox, when something else worked, people wouldn't be coming to our seminars for surgery. So it's amazing how many barriers are put in people's way that, in my opinion, are really discriminatory, and they're based on the fact that obesity is the last bastion of accepted prejudice.
No, I agree, and you're right. It is a multifactorial thing because there's emotional eating, and people, you just can't say. You're right. People say, oh, they just don't want to lose weight, but it's not it's not that simple.
Well, one of the most important things is, and I give a lot of talks around the world and lecture about new technologies and new procedures for obesity. Most of my colleagues believe obesity is a disease. I really don't, in my heart, believe that. I believe obesity is a lot like fever. And I'm borrowing from Dr. Christensen from Harvard, who actually teaches in their business school and is really very important in looking at new industries. And he's not a medical physician, and I think obesity is a symptom of an energy imbalance. Just like, if I told you last night my child had a fever of 101, you wouldn't know whether he had a throat infection, he had an ear infection, he had a viral syndrome, he could have something worse, he could have, it could be infectious, it could be immune, fever can come from a wide different things. It basically means that he had an immunologic state that provoked a fever response. I think obesity is the same way. So I don't think there's any two people that get to me the same way. Okay? Now, when you look at things from a societal, I think that's when you look at it from an individual standpoint. When you look at it from a societal standpoint, it's really, really strange. A lot has been written about emotional eating, or helicopter parenting and stuff like that. From a society standpoint, before 9/11 and before the economic downtime, I would actually say I was born in 1962. It was probably one of the least stressful times in American history. Mm-hmm. It had to be more stressful around the Depression, around World War II, when there was a draft in the Vietnam War.
Right.
So when we talk about emotional eating, if emotional eating, and girls have always been rejecting boys, and boys have been moving out of their house on their wives forever. I mean, these things aren't new to now. If it was emotional eating, you would expect the stresses in the society to correlate. And actually, we've probably had a more stressful society with the most recession, and for the first time, we're seeing a leveling off, not a decrease in the obesity epidemic. So I think there are environmental factors. That doesn't mean that people don't eat for emotional terms, but I don't think that the emotional stresses have changed in our life and are causing it. I think they're much more environmental, in terms of that. But that still takes us back to when we have people who have reached a certain point. I think as doctors, we need to begin to treat obesity with the same type of algorithms that we use in other treatments. So when you see somebody for hypertension, which means high blood pressure, what is the process that you go through? Usually
I educate them in things that they can do to change their blood pressure, the things they have control over, the smoking, the salt, the weight gain, exercise. Depending on how high their pressure is, then you go through that algorithm of which medications to put them on. But the first thing I do is educate them.
So the first thing is you document it, okay? and then you determine its degree of severity. So if it was 140 over 90 and they're smoking, you probably would start with a behavioral component and see
Right.
them back in a short period of time. If it was 200 over 110, you ain't going to just tell them to take the salt out of their diet and get a
Right.
call that, they have a headache and rushing to
They don't
Northern
leave
Western.
without a box.
They don't leave without a box. And then you would bring them back to see if you reach their clinical threshold. And if they didn't meet their clinical threshold, you would either raise the dose, change the agent, or add a second agent.
Right.
Okay? And then you would see them back, and you would titrate this to a clinical algorithm. Well, why aren't we doing the same thing with severe obesity when it causes medical problems? Why aren't we defining the severity of the situation? Why aren't we then saying, okay, let us look at this. You have early insulin resistance. Let us start
Right.
a 6-month real intensive program. Okay? And if it works, great. Let's keep on going back and doing that. But if not, let's go to the next level of treatment. Because believe it or not, when we segue into the operations, I actually believe that, there's so much marketing for bands, and bands work, but they actually work for the people who are less sick.
Right.
Okay.
Now, on that note, what we're going to do is this will be part 2 coming up, and then we'll be getting into his expertise and all the surgeries that are offered or that are out there. Thanks.
Okay?
Yep.